This technique video describes an all-arthroscopic approach to a suprapectoral biceps tenodesis with a knotless cortical tension-tight locking button technique. This case was performed at the Stedman Clinic in Vail, Colorado. Our patient is a 67-year-old right-hand dominant female who presents with long-standing left shoulder pain and persistent weakness, specifically with inability to perform overhead activity, which has been progressively worsening over several years. On examination, she has tenderness over the anterior medial shoulder and within the proximal bicipital groove, with weakness on internal rotation and a positive speeds test. Standard radiographs of left shoulder demonstrate no acute osseous abnormality, whereas preoperative MRI demonstrates irregular contour and increased intratendinous signal of the biceps tendon, most notably on the axial scan with slight medial subluxation. In the setting of medial subluxation of the biceps tendon, close attention should be placed for evaluation of an upper border of the subscapularis tear as it inserts on the lesser tuberosity. Therefore, in the setting of persistent shoulder dysfunction with evidence of biceps tendinopathy and possible upper border of the subscapularis tear, the plan was to proceed with diagnostic shoulder arthroscopy and potential rotator cuff repair with suprapectoral biceps tenodesis. Viewing within the subacromial space, the rotator cuff is identified and debrided with an arthroscopic shaver. A spinal needle is placed transcutaneously to anchor the long head of the biceps tendon proximally within the bicipital groove. The transverse humeral ligament is debrided down to its inferior-most attachment site at the bicipital groove, which serves as a landmark for our suprapectoral tenodesis site. The periosteum at our planned site of fixation is debrided with the bone-cutting shaver. A scorpion suture passer is used to perform the loop and tack construct. A loop is placed around the biceps tendon and the tack stitch is placed 5 to 7 millimeters distal. An advantage to the suprapectoral all-arthroscopic technique is the length-tension relationship of the biceps tendon is maintained prior to transection of the tendon from its proximal attachment site. It is important to pass your suture through the center of the biceps tendon to ensure that you have maximal biomechanical hold. A number 5 suture is loaded into the tension-tight locking button using a nitinol suture passer. A 3.7 millimeter spade drill tip is placed through the anterior superior arthroscopic portal and drilled at the planned site of fixation in a unicortical fashion. The locking button is inserted with the laser line facing superiorly. Gentle mallet taps can be utilized to facilitate passage of the locking button through the anterior cortex. The tension-tight locking button is deployed and the inserter remains in place while traction is applied to the number 5 suture for tensioning. Ensure the button has flipped prior to removing the metal inserter. To ensure proper fixation, each suture limb is tensioned individually to ensure that the locking button is fully seated. The suture is cut and the long head of the biceps tendon is detached superior to the loop and tack construct using arthroscopic scissors. At this point, the spinal needle is removed and the remaining portion of the intra-articular long head of the biceps tendon is addressed. The remaining stump of the proximal portion of the long head of the biceps tendon is removed to reveal a suprapectoral biceps tenodesis using an onlay technique with a tension-tight locking button.